is Jackie. And today we are going to give the medical grand round, and the topic is artificial intelligence in gastroenterology. So maybe we can start now due to the time limit. So okay, so first of all, I think we all heard about this term artificial intelligence in our daily living. So the key question is, what is artificial intelligence, or AI? So AI is a very broad term, and basically it is talking about the ability of a digital computer or any computer-controlled robots to perform simple tasks or even complicated tasks that is commonly associated with intelligent beings like human beings. And it mainly involves about learning and also problem solving. And the field of AI research was has a very long history, and the first reported history was in 1956, and it was started at a workshop at the Dartmouth College. And the main concept of AI, artificial intelligence, is very broad, as I said, and basically it consists of any computer programs that can mimic our human cognitive functions, such as the learning and also the problem solving. And this is a very broad term. And within it, there's more concise areas like what we also hear about the machine learning. And machine learning is basically as a computer method to analyze a lot of data, what we call big data, and it can give rise to a descriptive or any predictive models that can predict the long-term outcome. And an even more concise term would be a deep learning. And deep learning is basically a subset of machine learning. And this is very complex and depend on the artificial neural. And the key feature of it is it usually has some black box by the computer. So we as human beings, we don't know what the computers are thinking about, are calculating about, but we just know about the outcomes. So there are 3 layers of the artificial intelligence, and the deep learning is gaining most popularity recently. And as I've said, artificial intelligence can be divided into supervised learning and unsupervised learning. So supervised learning is basically still at the level of machine learning. So we human beings will give some instructions to the machines, and we also know about how to interpret and how to explain the results. On the contrary, unsupervised learning is mostly talking about deep learning. So the computers will just do the networking and also predict the outcomes and give us the final answer. But we don't know the reasoning, and we also don't know the algorithm. So there are 2 major different categories of the AI. And there are multiple AI models, and there are some more popular terms like the regression model or the decision tree or random forest. And neural network like the convoluted neural network is the most popular ones nowadays. It actually involves multiple layers of the learning. So it looks like a very complex tree and also a decision diagram. And it basically will give us multiple possibilities and also the final choices. And these are the popular models that are used by computers. An expert in this area, but these are what we are doing nowadays in our clinical practice. So the next question is, where are we now? Because AI is basically everywhere in our daily living. So as simple as search engines like Google or Yahoo, and secondly, there are some natural language interpretation like Siri in our iPhones. It also involves the AI technology. And also, the most popular cars nowadays is Tesla, which involves the autonomous driving. It also involves the AI concept. And last but not least, AI can also give some automated decision making, like the AlphaGo, which can beat the top chess players in the world as well. So where are we now in the medicine? And actually, AI is gaining more attention and also popularity in medicines nowadays as well. So it basically can be divided into data or images. So for data, it can help in giving us the diagnosis or the prediction of the prognosis of different diseases. While for image analysis, the most popular one would be the endoscopic photos, and also radiology and also pathology, like the histology slides, are also gaining popularity to combine with the use of the AI. So we can elaborate it very briefly in this introductive session. So in the next a few minutes, I will mainly focus on some introduction for the AI application in the field of gastroenterology. So first is talking about AI-assisted diagnosis. So a study led by Professor Grace Swan and also Terry previously can demonstrate that a machine learning model can actually diagnose non-alcoholic fatty liver disease in general population quite well, with an AURC up to 0.88. So this is basically a supervised learning. So we can retrieve what is the parameters that has the heaviest weight among all the big data parameters. So in this study, they developed a Neville-Rich score. So basically, it's by Rich regression, as shown in the lower end of the table. And when comparing different machine learning models, Rich regression performs the best in both the training cohort and also the validation cohort, with an quite satisfactory AURC. And the parameters inside it would mainly involve, apart from the liver function, it also involves some white cell count and also hypertension, which may be unrelated in our human thinking, but somehow this was included in the machine learning model and give quite a good end result. And secondly, AI can also help to predict prognosis in many diseases. And for example, this is a report published in Nature before from the Japanese group, and it made use of a machine learning algorithm in a lot of medical checkup data, like the big data center as well. So it involves the case control studies and use the XG gradient boost model. So it involves multiple parameters like the Helicobacter status, and also atrophic gastritis, whether the patient has gastrectomy, and also a few laboratory data. So it actually can predict whether a normal subject undergoing medical checkup will have a subsequent higher risk of future gastric cancer, with quite a satisfactory AURC up to 0.9. Apart from cancer, GI bleed can be also used for the AI-assisted prognosis. So this is a paper published by a group before, using a machine learning model to predict any recurrent bleeding from patients with previous peptic ulcer disease. So basically, we involve more than 20,000 of subjects in the training cohort, and also externally validated it in the prospective cohort. So the AURC is approaching 0.8 to predict the recurrent bleeding. So since these patients are quite prone for rebleeding in terms of its idiopathic etiology. So it can help us to guide whether we should continue long-term axis suppression therapy in these patients. And also another AI-assisted prognosis would be this landmark paper published in Gastroenterology from the Yale group. And Dennis actually analyzed a few thousand subjects in the training and also the validation cohort. And actually, for your information, since in the US, not all patients with upper GI bleed will be admitted to hospital. So this machine learning scoring system can help them to triage patients to be discharged home and come back for an early endoscopy, or to be admitted to hospital due to predicted worse outcomes. So in this particular study, they compared these machine learning models with the mostly commonly used clinical risk score, that is the Glasgow-Bradford score. So the AURC is better than the GBS, than the Rockwell score, and also than the AIM-65 score. So it helps to discriminate whether the patient has a low risk and can be discharged home to save some hospitalization costs as well. So apart from the data, images can be also involved in the rapidly developing AI field. So in the past 2 to 3 years, there are numerous papers and also RCTs published in the GI journals using the real-time computer-assisted AI tools to help to perform especially in colonoscopy, and also some trials are also published in the OGD as well. So I will leave this part to Jackie in the second part of the lecture. And for the basic concept, so AI assisted endoscopy can be further divided into that is the first, the CAT-E, which is helping to detect abnormality during the endoscopy, or the CAT-X, which is to help us to give a diagnosis in terms of the endoscopic appearance. So as you can see, there are numerous brands developing, and also this is a very rapidly developing field, and we will further elaborate this in the second part of the lecture. And apart from the endoscopy using the real-time AI assistance, the capsule endoscopy can be also involving the AI technology. So as a gastroenterologist, reading a capsule endoscopy reports is the most tedious and also time-consuming and probably boring job. And since with the AI development, the computer can actually first highlight the abnormal parts for us for a second review. So it may help us to save some time, and also save a lot of effort from the capsule reviewer. So this may be the new trend as well. And apart from the endoscopy, actually the pathologists can also benefit a lot from the AI. So there are numerous reports from in the recent 2 to 3 years. And actually, for your information, this is a technique called what we call a whole slide imaging, WLI. So basically, in the traditional pathology assessment, we usually will do the H&E staining and use the microscope to magnify it and read it by human eyes. But actually, the newer technology is we can just scan the whole pathology slide in the machine and then turn it into a computer-based pixels. And actually, once it turned into a computer signal, so it can be further generated into the convoluted neural network. So the computer can actually learn to read the slides. So this is a paper published in Nature 2 years ago as well. So since, as you all know, doing H&E staining is the basic for the histology assessment, but when we need to know specific markers, we need to do special staining as well. But for this AI model, it actually used a deep learning model, which the machine can already predict some microsatellite instability directly from the most simple H&E staining by using the neural network and achieving quite a satisfactory AURC to predict whether the sample has any MSI or not. And since this technology is rapidly developing, and there are 2 more papers published in the Lancet and the Science Report, also showing that the deep learning can actually predict the patient's outcome from the CRC cancer specimen. And it can further stratify the patient into a low-risk group or high-risk group. And then it can eventually actually guide the selection of whether we need to send the patient to receive any adjuvant treatment. And as a result, this is actually a personalized medicine. So previously, we will just follow the usual step, whether we should send the patient for first-line chemo, second-line chemo. But with this, we can actually select a better treatment algorithm for a specific patient. So this is can be more personalized as well with the use of the AI. So talking about the present tense, what should be the future of the AI with the rapidly developing technology? So this is the proposed ideal model. So we are actually living in a big data era. So we have a lot of data from the voice data, from the images, and also even from the wearable device like the Apple Watch. So with these numerous and also huge amount of data, so with the help of AI, so actually it can be further processed to find the unlinked, actually unknown linkage between different risk factors, so as to provide different levels of help in the future healthcare in terms of the primary prevention up to tertiary prevention. Like for example, it can help to triage the patient at the A&E, or it can help us to guide the selection of some drugs. And also it may actually help us to determine whether we should do any endoscopic therapy for a specific lesion when we found in the endoscopy. But talking about the good size of AI, we must stay alert. There will be future challenges. So this is a paper from Prof. Song. So basically, there are different levels of AI. So from level 0, there's no AI at all. From level 5, this is the full automation. So there will be different level of involvement of the computer and also human beings. So the main challenges would be, first, there may be some overfitting from the data. Or secondly, there may be some black box in the deep learning model. So it will eventually affect the interpretability or the explainability of the data and also the results, and leading to a mistrust from human to the machine. So this has to be solved before we can widely adopt it in clinical practice. And last but not least, ethical issues is another concern. Since we as doctors, we have to be responsible and also liable to our patients. But when we gradually switch to machines, so who should be the liable person, or whether we doctors or actually from the AI developers. So these remain a challenging questions to be settled before the AI technology can be further spread to our daily clinical practice. So with this, I would like to pass the airtime to Jackie for the second part of the lecture.
Thanks, Louis, for the excellent lecture and kind introduction. So good afternoon, everyone. I'm Jackie. And first of all, Happy New Year. And in the second part, I'd like to share with you some recent advances in artificial intelligence in endoscopy. So before talking about the artificial intelligence, let me go through some history of endoscopy. So on the left-hand side is the most primitive gastroscope, which was performed more than 150 years ago. At that time, clinicians would just use a rigid tube with a very rudimentary optical system to look into the interior of the patient. And basically what they do is by the use of mirror and also candle. But there were two major problems. First of all, is about the illumination, because the candle light is very dim. And this problem was solved about a decade afterwards, after the invention of incandescent light by Edison. And actually, the evolution of endoscopy goes on with and in parallel with some major inventions in human history. And for the rigid scope, the device was improved around 60 years later by Dr. Rudolf Schindler, and he developed a semi-rigid gastroscope with the shaft still being rigid, but the tip is a bendable tip. So with that, it can allow a more physiological insertion of the scope, and also reduce the patient discomfort, and also it enables a more thorough examination of the stomach, because a rigid tube is very difficult to visualize the whole stomach, and you can imagine that. But the totally flexible endoscope could also be made possible after the invention of fiber optic cable, and it was first introduced in the year 1957. And in the next 30 years, with the development of charged couple device, it actually revolutionized the whole system of endoscopy. And nowadays, we can have the very modern video endoscopy, and we can look at the very beautiful image on the video instead of looking at it with our bare eyes. But modern endoscopy is much more than just a plastic tube with a video screen. And actually, some companies and also the clinicians have worked jointly to develop various image enhanced techniques to improve the performance of endoscopy. This would include some virtual image enhanced endoscopy, including the very famous narrowband imaging. I'm sure some of you have heard about that before. And this is also very commonly used in our daily practice. And the image on the right-hand side is the narrowband imaging. The principle is that because different wavelength lights have different depth of penetration, so by only limiting the light source to the green and blue light, we can actually highlight the surface and vascular structure as seen in the photo here. And other virtual way of image enhanced endoscopy include the FICE and the blue light imaging, which were both products of the Fuji company, and also the iScan, which was produced by Pentest. And apart from virtual modalities, we also have some dye-based chromo endoscopy. So what we do is actually we just directly spray some dye onto the mucosa. And from this photo, we can see that on the white light image, the lesion just appear as some small nodules. But after the application of the dye, the border of the lesion becomes much more conspicuous. And if we take a closer look onto the surface of the lesion by using like some magnifying endoscope, we can actually see the surface structure much better. And this could help us to differentiate the nature of the lesion. And some common agents that we use for chromo endoscopy will be some absorptive agents like methylene blue and cristobalus, and also contrast agents like indigo carmine. And nowadays, we also have some more advanced modalities like the texture and color enhancement imaging, and also red dichromatic imaging, which were both produced by the Olympus company. And another exciting advancement would be the extended depth of field, or called EDOF. And for those of you who love photography, I'm sure you know what it is. So basically, the way it works is that it will split the light source into two different light beams with different focal ranges. And then the two different light beams will be projected onto the same sensory unit. And by doing so, no matter the object is at very near or far, they will both appear very clear on the video screen. And another recent exciting advancement would be the production of endocytoscope. It is actually a very special instrument which could provide up to 520 times magnification with the usual endoscopy setting. And by spraying the mucosa with some staining agents like methylene blue, we can actually examine the cellular level structures at the real time. So apart from image-enhanced endoscopy, there are also some device-assisted endoscopy method. So first of all, we have the soft black hood, which is commonly used in the setting of magnifying endoscope. And then we also have the plastic cap, which is commonly used in the examination of small bowel and also the colon. And also there are some commercially available devices such as the endocuff and the endoring, which were produced to try to push away the mucosal folds and allow better visualization for lesions that hide behind the folds. But with all these advances, how well are we doing during the colonoscopy? Actually, still not very good. So because a previous study have shown that the polyp miss rate is still very high in standard colonoscopy, with up to 26% for adenoma and also 9% for advanced adenomas. And this kind of missed polyp is associated with interval colorectal cancer. The diagram here is the adenoma carcinoma sequence that I'm sure you are very familiar with that. And by just missing 1 to 2 small polyps, it can already have great effects on the surveillance interval of a patient. And in that case, a patient may come back during the interval period with a colorectal cancer, which is definitely unwanted. And some previous studies have identified risk factors for missed polyps. So this can be due to inadequate mucosal exposure. For example, in proximal colon, because the control of the scope will be, will be more difficult in the proximal location. And another reason would be poor bowel preparation, which is very understandable because if the stool obscure the mucosa, then there is no way that you can see very clearly that area. And another reason for missed polyp is short withdrawal time. The international standard recommended withdrawal time would be at least 6 minutes because this could enable us to see every bit of the mucosa slowly. And of course, the polyp itself also matters. It's very understandable that small polyps are more prone to be missed. And also, not every polyp will stack out like these polyps. Some of them are what we call flat lesions, and it's very easy to be missed during endoscopy. So because pre-colonoscopy, the standard withdrawal time would be 6 minutes. In other words, for every mucosal fold, we can just have few seconds to look at the fold. So here is a little quiz. So there are 2 photos here. You have 5 seconds to see if there are any polyps, okay? Okay, time's up. So actually, there are a polyp in each of the photos. So first of all, there is a polyp here. And on the right-hand side, there is a polyp here. If you miss these polyps, don't be frustrated because even experienced endoscopists could miss this lesion. And another challenge that we face is that not all polyps are neoplastic. And remember the MBI technique that we mentioned before? First, actually classify the lesions based on their appearance under the MBI examination. And under the JNET classification, for type 1 lesion, majority of these lesions are hyperplastic polyp, which is very commonly encountered in the rectal sigmoid area, and they are completely benign and do not have any malignant potential. And actually, some doctors who advocate the diagnose and leave strategy, which means that whenever they see this kind of hyperplastic polyp, they'll just leave it behind. And if we resect every of these hyperplastic polyp, it may create unnecessary risk to the patient, like increase the risk of bleeding and perforation, and also it will create unnecessary workload to the endoscopist. So Professor Lau has given a very excellent talk about the AI in gastroenterology. So actually, gastroenterology is a field that AI can make a huge impact because diagnosis of GI disease relies a lot on image-based investigation and procedures like pathology, radiology, and endoscopy. And today, our focus will be on the endoscopy. So talking about the types of AI in endoscopy, it can be broadly classified into those used for quality control and those used for computer-aided detection, or in short, we call it CAD. So first of all, for quality control, examples would be some system that could ensure the completeness of examination during OGD. And then another potential area of development would be the lower GI part. So personally, as an endoscopist, sometimes we face the problem of endoscope slippage, which means that the scope suddenly come out very quickly. And every time if we encounter this situation, we need to insert the scope back to the original position. But it will be quite difficult to identify the original location. And if we did not make it back to the original point, we may actually miss some parts of the mucosa. And I know that there are some groups that are working on this kind of AI, and hopefully they will be used in clinical practice in the future. And the second major group of AI-assisted endoscopy will be CAD. And as Professor Lau said before, it can be further classified into those used for lesion detection, called CAD-E, or those used for lesion characterization, called CAD-X. And especially for CAD-X, this is a very important development, and is have a very huge potential, because we are now advocating the concept of optical biopsy, which means that we can instantly know the nature of a lesion by just looking at the structure and the surface pattern, etc. And by doing so, we can immediately get an idea of what is the lesion exactly and decide the management approach on site, and whether we should just leave it alone or we should leave it for some more further advanced resection techniques, etc. And how are these models developed? So Professor Lau have introduced the concept of deep learning. So it's a kind of machine learning that utilizes deep convolutional neural network. And so the difference from the traditional machine learning is that human intervention is not needed in deep learning. So basically how it actually works is that we'll just input some data into the deep learning system. And then the details of the data will be broken down into small pieces and stored in these dots, and each of them represents a neuron. And each neuron actually carries a weighting and also a bias value, which will be put in an activation function to decide which neurons on the next column will be activated. By doing so, it actually simulates the way that our brain works by the connection between neurons with action potential. And then this process go on. And finally, the pattern of neuronal excitation will actually determines the outcome of the initial data. And this process will self-perpetuate, and then finally a system could be developed to be used in the clinical practice. So next, I'll introduce to you some examples of AI-assisted endoscopy. So first of all, I'd like to introduce a system called Cerebro. So Cerebro is an AI system for OGD, and it is actually jointly designed by SteelHK and the Endovision Limited. And this we took reference from the systemic screening protocol for the stomach, which was proposed by Professor Kenshi Yao from Japan a few years ago. Because stomach itself is a moon-shaped structure, and if we do not have a systemic way of looking at it, we are bound to miss some lesion, and actually there are many blind spots that we need to be very careful. So in this Cerebro system, it is actually a station-based system with real-time recognition of 29 predefined locations. And it includes some gastric station, and also there is the esophagus, the duodenum, and also the hypopharynx, comprising 29 stations in total. And the endoscopist will be alerted if the sites were not inspected with adequate time. And by doing so, it can ensure the completeness of inspection, and it serve as a way to standardize and control the quality of OGD. So this is the systemic screening protocol for the stomach that I mentioned before. So actually there are 22 pictures included for the stomach, including for the antegrade view, 4 images from the antrum, the lower body, and also middle upper body. And on the retroflex view, we should take 4 images at the fundus cardia level, and also 3 images each from middle upper body and also the angular incisura. So here is a video for the cerebral system. So let me first briefly introduce the interface. So on the left-hand side is the luminal view of the endoscope. So basically, it's just the same as what we do in usual practice. But on the right-hand side, there is some checklists for each station. So we can see there are epiglottis, the vocal cord, esophagus, and also the stomach, and also the duodenum. So if you have adequately examined that area, the system will give you a tick. So let's play the video. So this video is played in a fast forward mode, so it moves very fast. And usually we look at it much slower. So this is the esophagus. And now we are moving down to the esophageal gastric junction. We'll be there very soon. Yes, this is the esophageal gastric junction. And this is the MBI examination. We can see that the mucosa are very distinct from the two areas. And then we are now in the stomach. And usually we'll go to the duodenum first to examine the duodenum and then come back to the stomach. And this is the D2. We can see some circular small bowel folds. And now we are in the stomach. We can see that after examination of the esophagus and duodenum with adequate time, the system will give you a tick. And it can actually detect the where you are automatically. You don't need to tell the machine where you are now to detect by itself. And now we are doing the inspection of the stomach. We're trying to flush away the bubbles and also suction out the fluid to ensure a good view. This is the angular incisura. And then we are doing the retroflexion because we are looking at the shaft of the endoscope. Yes, this is the retroflexion. We can see the shafts of the endoscope. And again, we will try to flush away the bubbles and also suction out the fluid. You can see that now we have completed 25 out of the 29 stations. And for the remaining stations, if they are not completed, the system will tell you, and you need to pay more time there. Okay, so now just one left, which is the antegrade view at the mid upper body. And we'll just skip that. Yes, we are taking some biopsy from the stomach. This is the biopsy forceps. Yes, so we have finished. So yeah, we got all the pictures here. So the next AI-assisted endoscopy system that I'd like to introduce is called EndoA. Actually, we are using this system during our routine colonoscopy now. It is a kind of TEC-E, which means that it is used for lesion detection. And it can allow real-time automatic detection of polyps under white light examination. And for this system, there is a console here, and it can be seamlessly incorporated into the usual colonoscopy. And there are 2 modes, including the target mode and also the standard mode. The picture on the upper part is the standard mode. This is a picture-in-picture interface. And on the right-hand side is the usual colonoscopy image. Whenever the system detects a polyp at the screen, it will show some green flags at the periphery of the image. And then on the screen, smaller screen, it will point out the exact lesion with a green cursor. But for the target mode, there's only one screen, and the lesion will be directly shown on the screen whenever the system detects a polyp. So here is a video of the EndoA. So we can see that now we are using the target mode. Only one screen is shown here. So this system is very powerful. We can see that it can detect very small polyp like this, even if they are hiding behind the fold. So when we switch to the NBI mode, the cursor is gone because this system is used under white light. And for this, we can see that multiple cursor can be shown at the same time, which means that it's capable of detecting multiple lesions simultaneously. And then we can see that this polyp has been resetted. And then when we withdraw the scope a bit, we can see that there is another small polyp hiding here. If we are not using the AI, probably we are going to miss this very small polyp actually. And then during polypectomy, this is a instrument what we call a Hausner. We are using it to grab the lesion and then use electrocautery to remove the lesion. We can see that even during polypectomy, the lesion will still show up on the screen as with a green cursor. Yeah, so the polyp is removed. So next, we have another system called the EndoBrain. EndoBrain is a kind of CAT-X, which means that it is used for lesion characterization, and it is designed for colonic endocytoscopy. So to recap, endocytoscope is a new instrument which can provide up to 520 times magnification, and it enables in vivo visualization of the colonic mucosa up to cellular level. So by looking at the colonic endocytoscope photo, the EndoBrain system could classify the lesion into one of the three pathological classes, namely cancer, adenoma, and non-neoplastic lesion. And the probability of prediction will be shown as percentage from 0 to 100. So here is the a video of the EndoBrain system. So first of all, let me introduce the interface. On the right-hand side is the usual colonoscopy image that we see. And the AI system is situated here. We can see that now the EndoBrain system is off, which means that we haven't turned on the system yet. So now we are seeing a flat lesion, and this is the cecum actually, because on the left upper corner is the seed-like structure, which is the appendiceal opening. And this flat lesion measures around 2 centimeters. And then after using the white light examination, we'll do chromoendoscopy to enhance the lesion. And then we just directly spray some dye on it. We use 1% methylene blue. And you can see that after spraying the dye on the lesion, the border becomes much more conspicuous. And if we take a closer look on the surface, the dye can also highlight the surface structure to allow characterization of the lesion. And then with the dye inside, we also use the NBI mode to further assist us in assessing the lesion. And we can see that most of the surface structure are some tubular and gyrus-like lesion, gyrus-like pattern, which is typical of adenomatous lesion. So this is the endocytoscope. We can see that in few seconds time, we are changing from a macroscopic view into a cellular level examination. So now the system has been turned on, the endocytoscope. So it gives a prediction of 99% neoplastic lesion. And then again, around 90% neoplastic prediction. So this is very compatible with the examination under the white light and also the NBI examination. So we are very confident that this lesion is a neoplastic one, and we should proceed to endoscopic resection. So having said that, with so many AI systems, does it really make a difference? Is there any evidence to support their use in clinical practice? So actually, the most well-studied area of AI-assisted endoscopy lies in the colonic CAT-E, which is the system used for lesion detection. So this is a meta-analysis published last year, including 4,300 patients within these clinical trials. And from this forest plot, we can see that colonic Cat-E is associated with a significantly increase in adenoma detection rate. The adenoma detection rate is strictly defined as the proportion of patients undergoing screening colonoscopy at which at least one adenoma is being discovered. And other than that, the study also found a significantly more adenoma per colonoscopy, and also more proximal polyp detected, and also more sessile-serrated lesion detected with the colonic Cat-E. These are very important findings because, as we mentioned before, the proximal location and also a sessile or flat lesions are risk factors for missed polyp. And on the other hand, an important point is that the study failed to demonstrate any significant increase in the detection of advanced adenoma, which is defined as lesions size of at least 1 centimeter or those exhibiting unfavorable histology. So other than colonic Cat-E, the performance of AI for other use is mainly evaluated by individual studies assessing their performance. So here we have an AI system called the EndoAngel, which is a novel artificial intelligence system for the assessment of bowel preparation. So as said before, a good bowel preparation is very important to enhance the ability of polyp detection. So nowadays, what we use to assess the bowel preparation is this BBPS. The full name is Boston Bowel Preparation Score. So in this score, it will divide the colon into the left colon, transverse colon, and right colon. And each segment will be given a score of 0 to 3 based on the presence of amount of stool present in that segment. So we can see that for the EndoAngel system, it can accurately assess the degree of bowel preparation and is superior to endoscopists, no matter the endoscopist is a novice, senior, or expert endoscopist. And regarding the EndoBrain system that we showed before, actually a study published from Japan also assessed the ability of EndoBrain in characterizing colonic lesion. So in this study, actually the author compared EndoBrain with endoscopists using MBI examination, because it was found previously that with human eyes, the MBI examination can actually provide the best ability to differentiate different colonic lesions. So the results show that even with the MBI assistance, the EndoBrain still outperform the trainee endoscopists in all the areas, including the sensitivity, specificity, and accuracy of lesion detection. And when compared with expert endoscopists, the EndoBrain still outperform expert in terms of the sensitivity. And this also holds true if the lesion is a minute lesion, defined as a dose of 5 or less millimeter. So with all those fascinating advancements in AI, we are still facing a lot of problems, as said by Professor Lau before. So first of all is we are uncertain if this AI system could actually benefit the patient in terms of the survival. Because taking the example of Cat-E, even an increase in the adenoma detection rate doesn't mean anything, because the detection of advanced adenoma is not increased. So we must critically scrutinize as in whether the detection of those non-advanced adenoma could really add any benefit to the survival. And of course, the AI also comes with the problem of false positive. And every time if we encounter a false positive lesion, we need to spend extra time to assess the lesion, and this may create unnecessary workload. And as well for trainee endoscopists like me, if we are incorporating AI into the daily practice, because AI is doing the job that our seniors used to do themselves before, so it may cause the skilling of endoscopists. And if we know that there is always a backup with AI, we might overlook some lesion because we just do not pay enough attention, knowing that there is backup by AI. And another problem is the lack of standardization and validation of AI system currently. And hopefully with the more studies published in the future, this could be improved. And finally, as Professor Lau mentioned before, there is also some ethical issue on the liability and legal area. But of course, I'm not an expert in this area, so I'm not going to talk about that today. So for the future development, I would say there are many exciting areas that await. So first of all is the standardization of CAD-E system, as mentioned before. And of course, we are also eagerly awaiting some more sophisticated CAD-X system, which could provide instantaneous diagnosis. And also, hopefully, this can be applied to other clinical situations like endoscopic hemostasis. And another very heated topic recently is robotics endoscopy. So it would be very exciting to see that AI could combine with robotics endoscopy in the future. And by the time our student graduates, I'm sure there will be many more exciting fields of AI being developed. So let's just be open-minded. So this is my last slide. So I hope that after today's sharing, you can recognize some limitations of conventional endoscopy, and then know about the ability of AI in endoscopy, in the quality control, in lesion detection, and also lesion characterization. And finally, although the current data are encouraging, further work is needed to solidify the integration of AI into our daily practice. So with that, I thank you very much, and any questions are welcome.
Thank you, Jackie, for your excellent talk. So this is the first medical grand round in the new year. So thank you for staying with us in the late evening. And I hope this sheds some light on the new development of the artificial intelligence in the new era. So welcome any question, and we wish you all a happy and also prospective new year in the coming year. Okay, I think I hope you all enjoy our sharing, and this is just a very brief introduction. And feel free to find us for further discussion if you find it is interesting. And probably we should end the Zoom meeting now. And thank you very much again for staying with us. And also wish you a happy new year. Thank you and bye-bye.
Bye-bye.